Good evening, everyone, and welcome to our bereavement webinar this evening. My name is Helene, and I'm the Workforce Development Officer at Western Victoria PHN, and I'll be your facilitator this evening. Alongside me is Jade, who's also one of the Workforce Development Officers here. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in for Wadawurrung country today. We recognise their diversity, resilience, and the ongoing place that the First Peoples hold in our communities. We pay our respects to elders, both past and present, and commit to working together in the spirits of mutual understanding, respect, and reconciliation. We support self-determination for First Peoples, Nations people, and organisations. Just a little bit of housekeeping. You can view the majority of our webinar recordings freely on our PHN YouTube, and Jade's got the link on the screen at the moment. And you can see all our upcoming events there, and you can also register them via the webinar. And the chat will be in the link if you'd like that. Please make note of our West Vic health pathways relating to this topic on the screen. And if you haven't entered the webinar and you're not displaying your accurate first and last name, could you please type your full name into the chat box? Only the admin will see this, and it's just for the to ensure us that we get your certificate and the name correct on that. For this evening's webinar, all participants will remain on mute. If you have any questions, just type them in the question and answer box, and they'll be addressed throughout the webinar. I think we'll do them at the end for this one, and it'll be anonymous, so your name won't be read out. And also, your feedback is important, so please take the time to complete the event survey after the webinar, and there'll also be a link to that in the chat box. Our presenters for this evening are Alyson Welch, who is the Bereavement and Traumatic of Sudden Deaths, Christine Rawson, and the How to Support a Bereaved Patient, and Cat Dumaresq, who is the Lived Experience Perspective. So I'll hand over to our first speaker, Alyson. Thanks, Alyson.
Thanks, Helene, for the introduction, and thank you to everybody for being here tonight. So we've got a lot to get through tonight, and I'm just going to make mention that some of the slides that you'll see, we're going to move through. I might move through quite quickly, and some will linger with a little bit longer, but you'll get copies of these slides later on, so you can go back and have a look at the things that we might move over a little bit faster. And I also just wanted to mention that 90 minutes, we've got 90 minutes tonight, and grief, particularly sudden, unexpected, and traumatic loss, grief after that is, it's a big topic. And 90 minutes doesn't do justice. We're barely scratching the surface on this topic tonight. So I really wanted to just acknowledge that. And, you know, in this space in grief and bereavement and traumatic loss, we at Hope, you know, we put space around it, and we usually go really slowly. And tonight is not going to be slow, unfortunately. So I just wanted to mention that as we kind of move into starting today's webinar. So again, thanks for being here. And what we're looking at here is an image and a quote from a children's book called Cry Heart But Never Break, that was voted amongst the top 10 children's books a couple of years ago by, I think it was Goodreads readers or something like that. And what it's really saying to us is that grief and love are really both, it's sort of that grief is the flip side of love, is sort of accurate and not accurate both at the same time, because it's not necessarily one side is grief and the other side of love. The way that I think about it is it's more of an interaction and a living process between them. And this quote, it's quite sweet, I think. Sorrow fell instantly in love and with delight, and she with him. And it was the same with grief and joy. Each couldn't live without the other. So we grieve because we love. And as you can see in the image, this person in the dark clothing's presenting the flowers to the lady in the dress, and yeah, sorrow and grief and love and joy really interacting with each other and trying to make a sort of connection in a way. So yeah, thanks, Sal. And the next slide we're going to look at, actually, this is a visual representation of the weight of grief depicted by an artist. And it really speaks to how grief can be a visceral experience and a physically felt experience. And some of the metaphors that you may have heard from your patients and possibly even experienced in some of your own experience, perhaps. I go through them, individually. They're pretty common metaphors that we hear. I would say, though, with a storm and a wave, a little tweak to that, I would say storms and waves, because, of course, grief ebbs, flows, and changes over time, and those waves and storms can come back. They come and they go over time. So, yeah, that's so. Many of us are familiar with Kubler-Ross's 5-stage model of grief, which she conceptualized. Well, I was looking today, actually, I was curious and wanted to remind myself of when she wrote On Death and Dying, that iconic text in which she first sort of introduced the world to this idea that grief, it goes through these 5 stages. And it was in the late 1960s, so it was a really long time ago. And I was also, reminded that in the early 2000s, I was working in an organisation where we were presenting psychoeducation groups, and one of the modules we spoke to was grief. And even as recent as the early 2000s, we still spoke to the 5 stages of grief, which just blows my mind. We certainly don't look at grief anymore as existing in these 5 stages. Certainly these elements of the 5 stages are part and can be part of the grief experience, but it doesn't move through one stage to the other. And in anticipatory grief, you may see a lot of people, I'm imagining, in your practice who experience anticipatory grief, sometimes called living grief. And that's, as it says, the kind of grief that's experienced by people long before death takes place. And it can be an experience that people can have for many years, actually, before a person dies. Living with people with carers can experience this. Even adults who are preparing for the death of their aging parents, people who are living with and caring for people with Alzheimer's, life-limiting illnesses, things like that. I think so. Yeah. The grief journey is normal, natural, and inevitable response to loss that impacts every aspect of our lives. I'm not going to go through these in detail because you'll be familiar with most of these, but I wouldn't mind just going ahead. Maybe just flick through them, Sal, and I'll just check whether there's any. Yeah, no, we can keep going there. And you can go back and have a look at these. These are all pretty, I don't think any of these will be surprising to you. The physical impact of grief and trauma, it can often be, I think, quite surprising for people. And people, as this says, can experience stomach pain and other pain. Gut issues can start to emerge, muscle tension and muscle pain, heart palpitations, and I'm thinking about broken heart syndrome. People can actually feel like they're having heart attacks. People can have panic attacks. It can impact. So thank you. I might there was something more I wanted to say on it, just really briefly. I'm just checking. Also, it's not there, but also breathlessness and respiratory conditions. And people can also, we know that grief and trauma can impact our immune system, which of course makes us more susceptible to colds and illness and things like that. So I think the physical effects of grief can be, just to repeat, really surprising for people, particularly body pain, which I think can be under-recognised for people. Behaviours and relationships, a lot of these will be familiar to you. People can sometimes can withdraw from others, but sometimes actually also people can feel like they want to, they need a hyper connection with others. They don't want to withdraw from others for many people, particularly if there's been a traumatic loss where the world doesn't feel safe anymore. Sometimes people can want to connect even more. Intolerance of other people. Spirituality and meaning making is a big one, particularly again in sudden and unexpected loss, because it can often it can be an existential shattering of a person's worldview. It can turn their view of how the world is meant to be completely upside down and inside out. So it can question spiritual, religious beliefs. It can really challenge our meaning making, the meaning making process. People can often feel and experience a loss of meaning and purpose in life, and it's with sudden and traumatic and unexpected loss, and suicide can be a big part of what people can start to experience, particularly if they don't feel like they get any relief from that. So often I think we live in a world where we want relief from these kinds of really intense experiences quickly. But the reality is that they don't happen. They don't move through us very quickly at all. It takes a lot of time to recover from, or not even recover. I don't know that you ever really fully recover, but to find a way to live with the experiences of sudden, traumatic, and unexpected death. Thanks, Sal. After death communication. So sometimes, quite often for people, after a loved one dies, they can experience the presence of the person who's died in many different ways, through dreams, coincidental occurrences. And, people can often be reminded or experience or feel like they're receiving messages even from their loved ones through seeing, they might have had a loved one who, for example, loved magpies, and they begin to see magpies everywhere, and that can really give them a sense of feeling an ongoing bond and an ongoing connection with their person. Sounds and smells, and it's on that list. Can also be ways that people connect. Just taking a moment to breathe. Determinants of grief. So there are so many variables that come into play when somebody loses somebody close to them. And the determinants of grief are what was the relationship like with the person who died and the circumstances surrounding the death, how the person died, previous losses and how they grieved, and also how they noticed how people around them were also grieving. Personality variables, you can sort of see all those there. You'll know a lot of these, but there's a lot of different experiences. It's such a deeply personal experience, grief, and there are a lot of things that can come into play when people are grieving. Thank you, Sally. This slide is sort of showing us that around the outside, all deaths matter. They're all meaningful. And because death and grief is such a personal, deeply personal and subjective experience, the deaths around the outside that represent what we might sort of describe as natural, normal deaths, or not normal, I don't like natural deaths, where people get the opportunity they might get the opportunity to prepare, such as if there's an illness or people coming to the end of their lives. People might have the opportunity to say goodbye, to make meaning of it, and to have time to prepare for it. And as we get closer into the center of the circle, you can see that suicide death is right in the middle. And what we know from the research is that suicide death is the most traumatic bereavement that anyone can experience. And that's in part because often people are left with far more questions than they will ever be able to have answers. So it really challenges people's capacity to make meaning. And often it's very hard for people to understand why their loved one would take their own life. And so even in sudden and violent death, of course, all loss is traumatic, and most loss is traumatic. But even in sudden and violent death, if there's a homicide, there can often still be the capacity or the capacity for people to get some of their questions answered. Not always, but they may still have the capacity to get their questions answered. Whereas in suicide death, people are often left with so many more questions that will never get answered. And it's really complex and very, very challenging as people are left to make their own meaning where there really is no meaning. And that can be incredibly, and is very, very traumatic for people. Thank you. So what is trauma? It's an event that pierces the mind and fractures everyday meanings. It's a physical and a psychological response. These are some of the ways that trauma has been described. A wound that penetrates the skin. It's also been described as a broken connection, because when someone experiences a traumatic event, it's unlike that outward circle where people get the opportunity to process and prepare and work through the death. With a traumatic event that's sudden and unexpected, it's too much, too quickly, happens too much and too quickly for the person to be able to process it. And so it inherently is disconnecting. It disconnects us from ourselves, from others, and from the world around us. And post-traumatic stress can come out of both being what we call direct sensory trauma. So that's where we're, for people who are actually directly witnessing or present at a traumatic event, where they're witnessing it through their eyes, but also auditory. People can hear a traumatic event and can develop post-traumatic stress out of that. But also that indirect trauma where they're provided with information or told about a traumatic event can also result in post-traumatic stress, because people develop flashbacks and images of the stories that they've heard. And we know that a big part of trauma is avoiding the situation. So people tend to avoid triggers or anything at all that can remind them of that event, situation, people's, places, the list goes on. And of course, hypervigilance. So inherently in trauma, the world where the world may have once been a safe place, it becomes an unsafe place. And there's a lot of survival energy that gets generated for people in trauma. And so it can feel like, so they're just trying to get through one day at a time, which can be incredibly, incredibly difficult, and also related to a lot of physical pain, because of course the musculature braces, and people are constantly on alert for the next thing that's gonna fall, the next, yeah. Thanks, so. Yeah. Gonna come back to grief now. We know grief is not sequential, and it's certainly not predictable. And again, particularly that's emphasized and amplified when there's been a traumatic loss. So again, the stages of grief, it's a bit hard to read those elements, but this would tells us that there are many, many different elements of the grief experience, but it doesn't, you know, it's not sequential. It doesn't go from one thing to another. It's more like the experience that's depicted on the right-hand side. It can be chaotic and go all over the place, yeah, and very different for different people. So at Hope, we there's a lot of different sort of models for looking at grief and ways of thinking about grief, and ways that we talk to people about what can be supportive when going through a grief process. And one of those is continuing bonds, which holds this idea that when somebody dies, a relationship doesn't end. So death ends a life, but not a relationship. And we know that finding ways to stay connected with loved ones can support the movement through acute grief. It says they're resolving grief, but I think resolve sort of implies that it ends. But again, it comes and goes, it ebbs and flows. But it can support people to just move through the intensity of the experience in the immediate aftermath of a loss. So we don't think about letting go anymore. And language is so important in the grief space and the way that we talk about it. So we don't talk about letting go or moving on. We use language like living with, and supporting people to, if it fits for them, because of course not every way of thinking about grief resonates for everybody. It's a very subjective experience. So for some people, maintaining bonds and finding ways to do that won't necessarily resonate. And the next slide actually is another way of looking at it, that again for some people will fit and for other people it won't. So we tend to think that grief shrinks over time. For some people it can feel like it shrinks over time. For other people it feels like it never goes away and it never actually shrinks, but they find ways to live with it and to find ways to live in the wake of a loss. So as you can see, the top jar is how some people do experience it. There's some people experience that. We heard a story from someone yesterday who said that for him it does feel like it's gotten smaller over time. For other people it feels like the grief stays the same, but life expands around it. Thank you. And just before I pass you over to Christine, just want to mention disenfranchised grief, which is the kind of grief that isn't openly acknowledged. It can people can feel like it's an invisible grief in a way, or not for them, but from the outside, that people don't see their experience. It's not socially accepted or publicly observed. And suicide grief can be like that for many people. Also things like pet loss, homicide, and different kinds of losses that are really hard for people to acknowledge as legitimate. Same-sex relationships, hopefully less as time goes on. Yeah. And so the antidote to disenfranchised grief and to supporting people to actually know that their grief is valid and legitimate is to acknowledge it, and let them know that it is valuable and important and their experience matters. I was speaking to someone the other day who was talking about who was bereaved by suicide, and they were actually saying to me that actually the loss of their son by suicide was a lot less traumatic than feeling invisible in the wake of that, because it wasn't acknowledged and hasn't been acknowledged for her, which was where for her the trauma was just further impacted. Yeah. So thank you. I'm going to hand you over to Christine now.
Thank you, Ali. So this part of the presentation is going to be around supporting a person bereaved. Grieving, as we've already heard from Ali, is a very unique journey, And one of the really important parts is to really listen actively and offer empathy and patience, avoid platitudes, and provide practical support to help them cope. I do want to take this opportunity to really acknowledge, in our experience as bereavement counsellors, we are able to sit with our clients and those who come to see us for up to an hour and sometimes more. And I can really appreciate that if you have someone come into your practice for a 10-15 minute consult who is traumatized and bereaved, it's not easy to be able to have and offer the time that that person perhaps requires. So I just really wanted to acknowledge that this is not me coming in and saying this is how you support a bereaved person, you need to allocate an extra hour per patient that comes in, but just really providing information about what we do and how we do it and what we find works in our experience. So most bereaved people do not require counselling or specialist support. So it's really important that we are aware that just sometimes simple reassurance and acknowledgement of their loss and access to information may be all that is required. I do see people who, in the early bereavement weeks and months, maybe even the first year, are not interested at all in doing any reading of any resources, whether it's online, in a book, fact sheets. More often than not, it's just an opportunity for them to sit and be heard and reassured and normalised. However, there is around, we're aware there's around, the statistics say there's around 10 to 20% of bereaved people who actually do have real difficulties in adjusting to the loss and do experience some very complicated grief that places them in more greater risk of adverse health effects. So we just, it's very much, again, a very unique experience for anyone that walks through your doors, and same for us. It's there's no one person that walked through with the same story or will be responding in the same way to a loss, or whether it's trauma loss or natural loss. It's important that we recognise and that we reassure people that there are no time limits. Years ago, there was this, funerals happened, it's a year now, you should be over it and move on. All the research now, all of what we know in all the theories is that grief does not stop, it changes. And so someone might be at 6 months and going really well. Someone might be at 6 months and still absolutely struggling. And it's about really recognising that that's okay, that's normal. And there is in society a sense that we need to be there fixing and prescribing medications. And I'm not telling you at all about how you do your job, but what we do know is sometimes for what we experience in our roles is actually sitting with that pain and not and certainly saying to them, we are not here to fix you or fix your pain. I don't have a handout here from 1 to 10 that is going to, you're going to walk out of here and it all will be well. I am here to sit with you and for you to process the painfulness of the loss, and to reassure and to normalise and provide strategies around what might help them. But it's about hearing their story first, seeking to understand. In the normal natural grief, that generally we say that it's between 2 to 3 years until people really feel like they're okay. And that's okay in terms of feeling like they've started to really integrate the loss into their lives. With suicide bereavement, the research states that it can be 4 to 5 years And the person has to go through and process and come to terms with the loss. And that's obviously not an easy thing for anybody to go through. We deal with what's presented right now and provide them with whatever strategies we can to help them cope and survive and exist. And as I said before, we have the time and we are able to really sit with them and hear their story and unpack where they are in the here and now. And yes, thanks, Al. We'll move on to the next one. So looking after yourself. Self-care is about ensuring you look after yourself without becoming your own doctor, which I was thinking I might take that out, but I think it's still very relevant because, all of us have to practice what we preach and what we propose and encourage our patients and clients to do. So it really is important that we look after all aspects of ourselves, the physical self, the mental self, the emotional and the social health. And understanding your own thoughts about death and bereavement. And we're all different depending on our spiritual, religious beliefs, values. And it's really important that we do recognize our limits and set boundaries. I know that for some people, they struggle with that, being able to set boundaries around what, not being a yes person or a no person. Someone said to me, I have become less of a people pleaser and a yes person. I actually have learned since the trauma of the death of my son to actually say, no, I'm not in a position to be able to do that. That doesn't work for me. So finding self-care strategies and accessing support as required. Just really just checking that I'm covering all things on that slide there. Establishing and working towards achieving goals and maintaining a work-life balance. And we all find that a challenge constantly. Implementing strategies to provide care and compassion to yourself. Accessing support as required. Support as required. So really, really making sure that there is that self-care. Thank you, Sally. So what they need, and I'm sure many of you already know all these already, that in your roles as doctors and other allied health workers in this webinar. We all need to be listened to, heard and understood in a non-judgmental way, and opportunity to tell their story over and over again. And that often is in the case of trauma, that opportunity to be able to, in that processing, being able to talk through the event and make sense of it rather than holding it in their head. That debrief. And when a person is in the early weeks of the bereavement, they're feeling intense pain. And again, we are not there to fix what is not fixable, but to make bearable the unbearable. And having a safe and supportive environment. And not everyone has that, but of course, that is going to pave the way for them to be able to move through their grief and being able to express their grief in their own way. Many people actually say, it's 3 weeks since the death and I feel worse. And I very, very quickly say, you're in such an early, intense phase of your grief. There is no way you could possibly be feeling in a good place or feeling like you should be, that would have, should have, could have, that so many people feel like they should be going better, that they're not coping. And more often than not, even just asking them, did you get up this morning? Did you have a shower? They say, well, yes, I did. I said, well, you're coping. If you can only do those things, those minor things, that's okay. That's just, you will find a way to cope. We can assist and support you in finding those strategies, whether that's from us or whether that's from us referring them on to other resources, which we'll move to a bit later. The grief does get worse before it gets better. And the funeral follow-up happens, people get on with their lives, family returns home and left, and so the person is left feeling quite alone. So what to say, so don't panic, normalize and stay there, sit with a person. I was talking to someone today, a father whose son suicided, and he said he doesn't need for someone to say lots and lots of words. He said just a hand on my arm, or just a hello, and how are you going, and I'm really sorry to hear about your loss. Just the simplest things can really allow someone to feel really acknowledged. And that turn there, I have no idea what to say, is incredibly acknowledging and powerful, because that sort of really shows a person who's bereaved that, hey, gosh, you're really placing some real significance in what I'm going through here. So that can be a really powerful phrase to use. Recognizing how hard it is for them. Share a memory if you have one, of the person. Perhaps if we say to people, if we're giving an information session or someone says, I don't know how to support someone who's grieving. If you knew the person that had died, share a memory of that person who died, and that can be really lovely to hear from the person who is bereaved. And sometimes it's something they didn't actually know about the person. Hopefully a good thing. And then ask what I can do to help. And sometimes people don't know, in those early days and weeks of trauma, they don't always know what it is they want, because they're in such turmoil, they're so shattered and in absolute shock. So sometimes it is about just offering the practical help. Thanks, Al. So I'm just going to have a bit of a breather from my voice for a little bit, whilst I'm just going to play a little snippet from many of you might know Brené Brown, and she talks a lot about empathy and sympathy, and sometimes those things of what to say and what not to say. So we're moving now into what to say, and this is a good example of that, of moving into this part of the presentation. Thanks, Sally.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, you climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, No, you want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, "I don't even know what to say right now. I'm just so glad you told me." Because the truth is, rarely can a response make something better. What makes something better is connection.
Thanks, Sally. And Brené Brown has a lot of really good resources around empathy and sympathy. And she's done a fair bit of work around shame as well over the years. Sally, I can't actually see the slides at the moment. Okay. Wonderful, thanks, Sally. So, what not to say, as we heard in that short YouTube clip. You know, don't make assumptions as to how they feel. Ask them how they feel. Don't try to fix things, as we've said already. As bereavement counsellors, it's not about us coming in to fix those people that walk through our doors. It's about sitting with, being with, and allowing them to talk about the person that died and what it means and the impact it's had on them that they are no longer in their world, and how are they going to move through their grief. There is, in those early weeks and early stages of grief, they have no idea how they are going to live in this world without that person. And it's scary, and it causes so much fear and worry, and so many of those emotions that we looked at earlier with Ali. Don't tell them that they will heal, move on, or get over it. Someone many years ago said to me, "I cannot use that word. I don't like to use or hear that word. Oh, you need to move on, or you'll move on soon." She said, "Because I feel that I'm actually abandoning my loved one when I use that word, move on." So many people like to use the word move through or moving forward, or they're probably the two main ones that people will mention. Be careful talking about religious ideas. That's a given, because unless you delve into that and they are openly wanting to share that, it's not for us to impart our own religious beliefs or spirituality upon them. Don't say, "I know how you feel." Focus on the person and what their story is. Seek to understand what is going on for them. This is what we do. And again, I re-emphasize, this is not, taking the time in a consult, in a 10-15 minute consult or an extended consult. It's not easy to delve into that deeper part of their story. And as Ali mentioned, don't talk about grief as a sequential, standardized process. It just takes people in all different directions. Thanks, Ali. So what to do? So we've already mentioned about impacts that loss has on our whole being, physical, behavioural, mental, emotional. So as doctors and allied health workers, it's so important to assess the patient's health, be aware that the bereavement is known to have, and being aware that bereavement is known to also have a significant impact on the health of surviving family members, and is certainly associated with increases in mortality. The physical side, the hollowness in the stomach, tightness in the throat or chest, oversensitivity to noise, sense of depersonalization, breathlessness, dry mouth, muscle weakness, lack of energy. No grief experience is the psychological self separate from the body. And sorry, Ali, you mentioned that before, but that's sort of really important to mention, that it's not just psychological or physical, it's all the whole person. So behavioural, obviously the crying and the sighing, and sort of that's obviously symptoms that you would see, and we have mentioned as well, the restlessness, overactivity, appetite disturbances, and just being very mindful and aware of some of those symptoms and behaviours that you see when they come in for consults. That social withdrawal, dreaming of the deceased, searching and calling out, visiting places associated with the deceased on a regular basis. Just being aware and just assessing whether they are talking constantly about that, or whether it's normal and it's managed, and they feel that the things like going to the cemetery are helpful for them, not that they're moving into a space where they are not functioning and doing anything else. They're fixated in just going to the cemetery and all the time, and not really doing things to self-care and manage and tap into some of those things that will soothe, particularly around the trauma, the importance of soothing, finding ways to soothe and to regain a sense of control in their life. Because when the trauma's happened, the assumption of how the world is meant to be is completely shattered. And so we need to encourage them to regain a sense of being in control of their lives and their world. Thanks, Sal. So what to do? Assessing the risk factors in bereavement related to the situational risk factors, individual risk factors, and interpersonal risk factors. So the situational risk factors, that's whether it's a sudden death, a death of a child, or a traumatic death, preventable death, or overly prolonged dying, or absence of the body. I was speaking with a young woman the other day, and her mother died overseas, and the body the body was cremated overseas, and the ashes were brought back, and she had no opportunity to see her mother, and processing, 1 minute mum was fine and the next minute she was going on holiday and was meant to come back from holiday and never did. And so her ability, and even just having a funeral with a cask, all of the whole ritual and the saying goodbye she was fully deprived of. The individual risk factors, so what previous losses have just being mindful and assessing, are there any previous losses or traumas in their life, how they dealt with those at that time, how they resolved those, and we can use how they move through their grief back then as a way of saying, well, you used that then, did that work? Will it work now if you use some of those strategies now? Whether there was a past history of psychiatric illness, previous depression, alcohol, drug use, eating disorders, and concurrent crises, gender, religious beliefs, low self-esteem. So really assessing and being aware and mindful of some of those factors. And then the interpersonal risk factors, you know, the centrality of the relationship with the deceased, decreased role diversity, lack of social supports, and ambivalence, unavailability of social and emotional support from family and friends. And, you know, that can be incredibly challenging, particularly after the funeral. And as I said, in that first 3 months to the year, when friends and family do start to move through and get on with their own lives and go back to work and return to their lives, and you're left then feeling really quite isolated and lacking that intensive support that they would have got early on. Thanks, Sally. So now what? So really normalizing the grief process, and really recognizing that grief is change, grief is impermanent, and there's constant change in people's lives, change in relationships, change in perhaps lifestyle circumstances, jobs, where they live, who they live with, change of sense of who they are in the world. And there's constant change. So finding ways to promote resilience in a person and look and seek out those supports where they feel eased, and supports they feel eased when they've been around people, certain people. Sometimes we talk about the address book changes, and a person who has an address book where there are people that have been in your address book, and when there's been a significant loss in their lives and they're bereaved, some people really step up and are there and are amazingly supportive, and then those people that they thought would be there and available to them, they don't see them, they're avoided. And then there are new people that come into the address book who they happen to meet because of the loss and the death, and that happens obviously through the support groups that we run at Hope. A lot of people make connections with people who have experienced the same type of bereavement, and through that, you know, meeting with people that get it, so they don't feel so lonely in their grief, can be incredibly powerful, and that changes, you know, the structure of their address book. But really encouraging people to seek out the people that really they feel eased and comforted by and soothed by. Providing information about resources available, websites, apps, phone lines, that's incredibly important. And I'm sure that, you know, you do have access to a lot of those resources. And we've got a slide in a couple of slides where we provide those resources. And then if the patient asks to refer to specialist services, make a referral to a bereavement service or counselling service. You know, if you feel that you know, in your time available, you don't have capacity to support that person, that patient, please do, you know, really look and consider what options there are out there. And I know, we all recognise the limitations and restrictions and challenges and difficulties of finding psychologists and psychiatrists in a timely manner these days, which is concerning. But yeah, it's kind of trying to find as many ways as possible just to hold them until perhaps that psychology appointment or psychiatrist appointment is available. Thank you, Sally. And yeah, just really wanting to re-emphasize, just validating and reassuring that they are coping, even if you know, they say they're not sleeping well, and they're only just managing to shower, and they may be eating a lot, or they're not eating very much at all. Just even if they do say, well, I did go down to the park and I did walk around the block, just really acknowledging when they are expressing how they're coping the best way they can, and that's okay. And that particularly for us in the bereavement space, when someone's gone through a significant trauma, we say to people, particularly in that suicide bereavement space, it won't be like this forever. And I've worked with numerous people, and there is that absolute feeling of, I don't think my life is ever going to be in any way, shape or form back to any normality. I feel like I'm just going to be stuck here forever. And we have that time. We can sit with these people who come to see us and just say, I'm comfortable. I can sit here with you, and I can hear your pain and listen to your pain, and I can absolutely reassure you it won't feel this way forever. And for some people, they may well need to move into the space of having medication and antidepressants. And that's totally fine. If for some people, it does take the edge off. But we have had people who come to us and they say, I've been on antidepressants, I've come off them, and now I still feel worse. It's almost like I feel like it was masking my grief, and it hasn't changed my grief, and I'm still still struggling, or it's worse. So there is absolutely a place for medication, but I think there is also, it's really important, going back to that previous slide where we talked about don't panic, but sometimes just being able to sit with and be with someone, and hearing their story, allowing them the opportunity to express what is happening to them for the here and now, and not placing too much pressure to be thinking a week, a month, a year ahead, but just really reassuring that where they're at right now is not going to remain in that way. It will change. Things will change. Things will shift. But obviously there are exceptions to the rule with that, and that is where that extra specialised psychological referral would be necessary. And that does happen for us as well, where we feel we do need to refer for someone to have some more specific and specialised psychological support. Okay, thanks, Sal. Bereavement counselling and support. So when to consider additional supports when people are feeling isolated, their task of daily life cannot be managed, mental health crisis, persistent thoughts of suicide, substance use, no change over time, so they're just not, they're stuck, and that's where we sort of move into the realms of complicated grief and complex grief. If the person feels for whatever reason that they need help to get through this experience. Of course, we at Hope Bereavement are available to provide that. And there are also, as mentioned there on that slide, there's Grief Line, which is the phone service, and Grief Australia, and they were formerly Australian Centre for Grief and Bereavement. And they predominantly do telehealth counselling now. Thanks, Hal. Just one other thing, actually, I did meant to mention on that previous slide. So if someone's in a mental health crisis, and there are those persistent thoughts of suicide, and there is persistent overuse of alcohol or other drugs, and panic attacks, anxiety issues, or depression are experienced. That's really when those additional supports, like ourselves, are really necessary. And then over time, the person remains preoccupied and acutely distressed. So I think that is, we have come to the end of the slides. So grief is part of life. It is not an illness. It is a life experience. Thank you very much for listening, and I hand over to Kat, who will be speaking her lived experience. Thanks, Kat.
Thanks, Christine. So I'm doing something a little bit different tonight, so bear with me. I'm going to give you a snippet of my lived experience, my living experience, because it hasn't finished yet. So Jared, my husband, died in January of 2016 when he was 48 years old. We'd been married for just shy of 16 years. And my life's been a journey I didn't expect it to be, but how many of us can say that? When I met Jer, he was tall, fit, intelligent, kind, funny, and a really sweet man. He was separated and he was a psychiatric nurse. So was I. And I had one rule in my life: don't ever get involved with psych nurses because they're very strange people. But I did get involved and we ended up married. He had 2 children and then we had 2 more. So quite quickly our family grew and we needed a bigger car. But Jer was always enthusiastic in his life. We enjoyed catching up with friends, live music. We went to festivals, lots of social occasions, and we had a nice life. When our youngest child was about 6, Jared made the first attempt to take his life. And we ended up in the emergency department. He was treated. He was sent home for me to look after him. And my belief in our strength as a couple was shattered. His promise to not leave me or the kids was broken. And I basically became his carer. Now, we both worked in mental health, but I worked in mental health, so I should have been able to see it coming. I should have been able to prevent it. And I should have been able to fix it. Jer was referred to a psychiatrist. He was diagnosed with depression and he started on medication. And that didn't help him a huge amount, but turns out he'd also suffered from a childhood trauma that was really significant. He had many head knocks as a keen young footballer, and he had chronic gut issues. And with what we now know about CTE and gut biomes, I often wonder if the outcome could have been different. We both enjoyed alcohol socially, but around 2014, that swiftly escalated to the point where Jared's drinking was out of control. He lost his license, he lost his job, and he was arrested on one occasion, which was humiliating for him. But his need to self-medicate and numb his pain was unfortunately even greater. And there were several more attempts to take his life. We had ambulances attending to our house, at emergency department visits, where we were made to feel that perhaps, maybe I was being sensitive, but made to feel that we were taking up services that could perhaps have been better used for someone else. And there was one occasion Jer was admitted to intensive care. He was kept in a medically induced coma for several days. And after that, he had even less impulse control. I think he may have had a brain injury and even more shame. So we tried detox. He went up to a private clinic, but he only stayed the weekend and he didn't actually even start the program. I think he was quite terrified to stop numbing his pain. So Jer's death was sudden and it was unexpected, even though he'd had several years before he died struggling with addiction and mental health. When I found him in our yard, it was a shock. My first reaction was absolute disbelief, and that followed quickly with numbness. I experienced this bizarre sensation of detachment from things that were happening around me, which I presume allowed me to survive and continue to function at some level. And once upon a time, I would joke that nothing could ever stop me from sleeping or eating, were 2 of my greatest talents, but acute grief did. And ongoingly, grief still can when it comes in those big waves. I felt that people had an expectation that we were going to be able to do better by the time his funeral was over, but the reality of what had happened to us hadn't even found us yet. Life was very robotic, it was painful, and it was also strangely numb. So it took a few months for my adrenaline to start to dissipate, and what I was left with then was just sadness, guilt. I was terrified. I was angry. I've never been so angry in my life. had a sense of hopelessness and overwhelm. I also had some relief, and there was horror at what my life had become, all in swirling, undulating waves of emotion, the likes of which I don't think I'd ever felt before. And I was surprised by the level of physical symptoms I experienced. I had headaches, nausea, aching muscles. I think we caught every virus that was going past in the next couple of years, and I was so tired. I think from holding myself together to even just get out of bed, I was so tired. It was exhausting just to get up to go to the shop or to go to the lounge room, but I also needed to do that because I had a family I had to support. And all of this went on and on and on. And it was about 6 months before I could go back to my job as a perinatal mental health counsellor. But I had a 12-year-old daughter at the time who started at a new school in year 7 on the Monday after her dad's funeral on the previous Friday, so 3 days after we had his funeral. She wanted to go to school because she wanted to fit in. So that's not to say her attendance was great, but she was determined to start her secondary school years as normal as possible. And I thought that was a really good example of how different we all are in our grief journeys. So when I did return to my normal life, I was different, and I'm still very different. I think I don't sweat the small stuff so much, like it was said before. And I think I have got perhaps a better tolerance of people. Some may disagree. But my roles in life had changed. I wasn't a wife anymore. I'm a widow. I hate that word. I'm a single parent. And I'm a sole mortgage payer. And the person that was supposed to support me in our life was gone. Sorry. So while he was unwell, I at least had hope that things could change and he might recover. But now that hope had gone. My confidence hit rock bottom, and simple things that I could easily achieve prior seemed quite mountainous. But I had to fight through, and I had to get up to take my kids to their lives, even when I wasn't ready to re-enter mine. And then amongst all of this, I also did feel some gratitude. I was really grateful that my kids didn't find their dad. I was grateful to my family and friends for their support. I was grateful for the many trays of lasagna that were delivered to my brother's house where we were initially staying. I was grateful to the services that helped me during this time, which included Hope. And I was really grateful to my long-term GP. I was, and I'm still lucky enough to have a family GP. And I know that probably makes me sound old. Not a lot of people are able to have that with the system, perhaps, as it is now, because it's so busy. But my GP had been in my life before I met Jared. He provided my care when I was pregnant with my babies. He assisted at my Caesars. And he literally knows me inside and out. He listened to me when I was an anxious parent. He immunised my kids. When I was scared that they might catch autism from the MMR vaccine, he gave me great reassurance. And he was there for me at the toughest time of my life. So for several years before Jared died, and then ongoingly after his death. And he also supported Jared during his tough times. So what he did for me was amazing and simple all at once. He listened to me and he heard what I said, and he's not ever professed to be the expert in my grief journey, but he will gently offer me suggestions if I feel stuck or unable to make decisions. And I found the other GPs in the practice are also amazing. And unfortunately, I know most of them now because of, probably because of my anxiety and my reactions to what was happening in my life, but also our vulnerability to infections and things like that. So what I like about the practice is that I don't need to ask where I don't need to explain myself over and over again. If I need some time away from work or life, they're very supportive of us. And if the kids needed time off school, they were very supportive to them too. And we don't need to tell our story each time, which is a huge relief. There was one experience about 2 years after Jared's death when I met a new person in the practice, and I had gone to ask for a certificate for some time off because there seems to be a continuing period of grief exacerbation, I'll call it, that starts just before the anniversary of Jer's death and continues for a couple of days afterwards. And I usually feel quite exhausted and I need to increase my self-care. So that still occurs now, but I know I need to schedule a brief holiday around that time, and that works okay for me. And it gives me time to do some nice memorial activities with the kids. But I hadn't quite put that together at that stage. So I went and saw the doctor, and this guy was very efficient, but he was also very quick to tell me I wasn't coping very well. He gave me a mental health care plan and a prescription for antidepressants, neither of which I wanted. And I'd discussed that with my GP before, so I didn't use either of them. And I already had good counselling, so I didn't want to use the mental health care plan. And I'd done some trauma-based therapy as well. But I left that day feeling that I was somehow failing in my grief. And I was also pretty pissed off that I hadn't been heard. So that wasn't great for me. So it has been my choice not to use medication to relieve my grief. I truly believe it's a journey that can't be sped up, not by working harder at it, and it can't be soothed with prescription or illicit drugs. It needs to be felt for us to be able to integrate the loss into our new selves in a functional way, and it just takes time. The pain of grief ebbs and flows like the tide, sometimes gentle waves that lap at your ankles, and an occasional giant wave that knocks your feet out from under you, and it takes your breath away. But I find the longer time passes, the less giant waves there are, and the more quickly I can get up and dry off and just get on with things. I do struggle with ongoing and secondary losses though. Teaching our youngest 2 kids to drive, them graduating from school and one university, their Deb balls, special days like Christmas, Father's Day, Jer's birthday, our birthdays. You get what I'm saying, I guess. And although I have beautiful people around me, it often feels so lonely because the person I would stand with or call at these times isn't there. So, and we also now have 2 beautiful grandsons. So Gordy's 2. Sorry, Nadi's 6 months. And I know that Jared would have been an absolutely doting opa or pop, but we never got to hear what name that would be. I've spent a lot of time in the last 8 years reflecting on our life and those of our kids and how Jared's death has impacted us. And I'm not really sure how I would have gotten through this experience without the support of Annie, who was my counsellor, and Hope. And it wasn't just the counselling, which was integral, but it was also the groups where I met people with similar experience, so I didn't have to feel so isolated. And then I was given the opportunity to give back when I was ready, and I could volunteer, which gave me a sense of purpose and confidence to live fully again. And now with some extra education, my livelihood, because I work there. Unfortunately, I don't think, actually I know that ongoing specialist bereavement support's not valued or properly funded. And I think that's because people that haven't experienced sudden or unexpected losses, such as suicide or baby and child loss, don't quite get how it feels and how it stays in us. And I recently found out that mental health services are going to take over providing bereavement counselling, which I find really concerning, because not only will they then be responsible for mental health, alcohol and other drugs, and bereavement, and I don't think they have the capacity or the skills to do it. And it makes me really sad because it was so beneficial to me in my recovery and integration of my grief. Anyway, aside from the obvious grief, I believe losing Jer has made us more compassionate, honest, and able to be vulnerable with each other. And it's also left us with a knowing that really bad things do happen in life. But when they do, you can continue to live and not just exist. And that you need to make the most of whatever time you've got with those you love. So, yeah. Thank you for listening to me. And thank you for giving me the opportunity to say Jared's name, because that does help. And unfortunately, you can see how that 8 years later, that can still sometimes just take over. So thanks.
So that's okay, so that's kind of it from us. I'm Sally. You haven't met me, but you've heard my name many, many times. Just got some a final slide here, which is just about from having a look through a lot of the research around best practice for GP clinics. It may or may not be things that you can integrate, but these are the things that have come up that have been kind of researched, and the research around bereavements is fairly hit and miss. There's lots of areas that haven't been looked at, and there's lots of areas that have that still appear not to be implemented. But around GPs specifically and bereavement, there's not a lot. So, but the things is around just we know the links between people that are bereaved and poor mental health and poor physical health outcomes. So, so that makes it very much the business of what you guys are doing all the time, and I'm sure you are doing it. So some of the best practices having a bit of a sense in your practice about people that are bereaved, and so that you can sort of code for that, because some of the systems don't allow you to code for that. It's really hard to put information about something additional on systems. So somebody that's not your client, so you can't necessarily have that, but that stops situations where people go into a GP clinic, see another GP, and there might be a note about a pregnancy, and they'll be asked about their baby that had died, but it's not, you know, listed on the medical records or those sorts of things. So that can be really helpful. That everyone in the practice just has a response. So it doesn't have to be the GP that makes a follow-up phone call, but it might just be checking in and then just ask what works, check if the practice have supported. So there's just a few things that through that we've, you know, been looking up that seem to be helpful. But that's it from us. And if you've got any questions for the wonderful Alyson, Kat, or Christine, you can pop them in the chat and we can answer them, or we can finish 10 minutes early, which is very rare.
Thank you all for your presentations. It was great to have so much expertise on this topic. I found it really moving. Thank you, Catherine, for your presentation and the excellent talks from Alyson and Christine, and with input from Sally. That was an absolutely amazing webinar. But there are no questions coming in at this stage, but we do have time, so we can give it a few more minutes. If you've got any questions, pop them in the question and answer or the chat box, and we can certainly answer them for you. If not, and you prefer to speak to one of these off air, I'm sure that I can provide their email or a contact number for them. Has any of the speakers got any final words that they would like to part with us?
Just to say that we're all living in a time in our region where there's been some significant deaths by suicide in our region, and some other sudden and unexpected deaths. So reminding us, because we all live in West Vic, well, most of us, I assume, that have that are logged on tonight, it means that not only are we the ones that are talking to people that are bereaved, but we're also the ones trying to support other people. So just that, what Christine was talking about in terms of self-care, just really reminding yourselves that, you know, as a part of the community, they are your neighbours, your friends, your community members. So it is really hard work sometimes to support people bereaved, particularly where you're impacted yourselves. So, but I want to thank the incredible staff as well. They're amazing.
Thank you all. There's no questions, so we will end it there. Please don't forget to fill in your evaluation, and if there's any topics on any of this that we discussed tonight or anything else, please pop them in, because we're only too happy to run some more webinars on what you would like. And thank you again to all the speakers for taking the time out for this evening. Bye, everyone.